Welcome to our webinar on institutional special needs plans. We're very excited to have some esteemed panelists to share some inside information on how to work with iSNPs and what the benefits to skilled nursing facilities are. I'm Laura McKee, one of the co-founders and the COO of Hucu. Hucu is a provider of coordinated communication services to post-acute care, and we are excited to present. So I'm pleased to have Daniel Kroyman's General Manager and Vice President of Value-Based Care at SCAN Health Plans and the leader of the SCAN Embrace organization. Daniel, would you like to say a few words about yourself and your organization?
Yeah, hey, thank you, Hucu team, for the invite. Really happy to be here. Try to be brief. I get excited about what we do at SCAN. But as general manager of Embrace, Embrace is SCAN's integrated health plan, particularly the iSNP model and care delivery team that is solely focused on providing mobile comprehensive primary care to seniors in senior living communities. Today, we do that in California and Arizona. We're in assisted living, memory care, SNF long-term care, independent, boarding care, group homes, we started serving our first patients in January 2022. As an integrated team, we fully manage every aspect of care for those individuals that elect us on the health plan and medical group side of things. I'm also a physician by training, a primary care doc. I jumped into this role in a non-clinical role to help manage, I think is a very clinical forward business. And I do now have a small practice in San Fernando Valley where I live. And just really excited to talk to you guys here about our experience, answer any questions that you have. Before I hand it over actually to my one of my co speakers here, I'll just be brief about SCAN. As some of you may know, SCAN stands for Senior Care Action Network, which is a not-for-profit Medicare Advantage plan that was founded in the 1970s by what we endearingly call our 12 angry seniors. They were fed up with the care that they were receiving or lack thereof and came together to form a coalition and think about how could they actually help seniors live healthy and independent lives. That has evolved from a pure nonprofit local Medicare Advantage plan into a nonprofit healthcare organization, which is now in a number of states on the West Coast. That is, with that evolution, we've leaned into care delivery in areas like Embrace. We've leaned into care delivery for homeless individuals in areas in an organization called Healthcare in Action. We have a PACE program, which is led by our My Place business and a number of other entities. And excited to share some of that experience with you guys all today.
Thank you so much, Daniel. I did not know about SCAN's grassroots history. That's really awesome. And I'd like to introduce our second panelist, Jill Lyle Sumner. Jill, why don't you share a little bit about your background and your organization?
Thanks, Laura. Dan, I'm going to be one of those next generation of 12 angry people if we don't do better taking care of our older adults and if there's not a scan available for me in 10 years. Um, Thanks so much, Laura and Faizan, for having us both. My name's Jill Lyle Sumner. I am the founder and president of Lyle Health Advisors. I help providers, long-term care providers, facility providers, geriatricians, look at their options when it comes to value-based care, how to engage, how to evaluate your opportunities, and then what it takes to actually implement and be successful. I come to this after 20 so years working on both the provider side. I've been a nursing home administrator, worked in the large corporate offices of nursing home chains, as well as developing Medicare Advantage plans, D-SNPs, I-SNPs, C-SNPs. So have spanned both of those areas, and then also worked at the national level for both Leading Age and ACA, developing all of their value-based care programming over the past 15 years. So it's great to be here and happy to engage in this conversation.
Thank you so much, Jill. We're really lucky to have two experts in this area help us really dig in and learn more about iSNPs and the benefits of working with iSNPs. So specifically, we'll cover the learning objectives. If you are here, it's hopefully because you want to learn more about the benefits of skilled nursing and post-acute providers participating in institutionalized special needs plans. We'll explain what they are, and most importantly, and secondly, will help you think about how you can engage in an iSNP partnership if you're interested. So first off, we'll do a quick poll to see who's here. So if you are interested in this topic, what is the level of knowledge that you have already? Have you already participated in multiple special needs plans or worked with multiple special needs providers? Have you participated with at least one institutional special needs plan? Are you considering partnering? Are you just here to learn? Or you really are just here on an informational basis and don't know much at all? If you're not sure, feel free to click not sure. And while people are responding to that poll, just to provide a little bit of motivation, um, we'll talk about why institutional special needs plans are gaining in popularity. Most of us are aware that CMS has issued a goal of having 100% of Medicare beneficiaries in some form of value-based care, meaning that they're in a, risk-sharing plan by 2030. So that's really, just around the corner. If you've got a kid heading off to college in the fall, then you better have your parents or your seniors on a value-based plan by the end of this decade. Do we have results in the poll? Okay, it looks like the folks who are on are participating with an institutional special needs plan, and some are just learning about iSNPs, some are not sure. So we'll cover the gamut of your interests. Thank you for participating in the poll. So, yeah, a little background. Some really interesting research is coming out about the quality of care that's provided to people in iSNPs. So, the members in iSNPs are experiencing lower emergency room rates, lower hospitalization rates, better outcomes by a variety of metrics, including infections, the lack of pressure ulcers, and other falls and major injuries. And that's because of the quality of care that iSNP providers are able to provide. So, not surprisingly, enrollment continues to increase in these types of plans over the course of 2023 to 2026. The percentage of Medicare Advantage plan participants who are enrolled in iSNPs has increased to 1 in 4. So they are representing a larger and larger proportion of Medicare Advantage plan beneficiaries. So this is a really growing and important part of post-acute care, and that's why, we want to make sure people understand the benefits and what's driving that growth. So let's jump right in. So, for those who are less familiar with institutional special needs plans, Daniel, can you give a little bit of an overview of what an iSNP is and what the benefits are?
Yeah, of course. And, Jill, feel free to jump in. I've learned a lot from you over the years. But I better get this one right. So an institutional special needs plan is a specialized type of Medicare Advantage plan, and it is designed specifically for residents that are receiving some form of institutional level care. Initially, this started off being a real focus for the SNF long-term care space, and it's now continued to broaden to serve a broader population of seniors that are living in aggregate senior living, whether that be assisted living, even independent memory care, boarding care. Um, Another difference is as a special needs plan, we're able to enroll individuals year round versus the typical Medicare enrollment period, which happens between October and December every year. And there are a couple other differences between a traditional Medicare Advantage plan and even other insurance options that I wanted to highlight. I think, three that come to mind. One, for an iSNP, there is a Medicare, rigorously vetted model of care that's approved. that requires a level of embedded clinical team, care coordination, and how they support the residents and your staff in the building. That's a part of a submission to Medicare, and is part of this iSNP plan type. Second, the institutional special needs plan is fully risk bearing, meaning when the plan is coming forward, they're coming forward with their care team, one of your residents enrolls into the plan. That plan, that care team is much more aligned around total cost of care management. And I think that that creates an opportunity to generally or genuinely align with your incentives and your kind of interest and passion in supporting your residents and keeping them healthy, stable, and in your community and thriving. Third, and I think this is the most important part, this is like it creates a real shift from the SNF being what is often like a downstream cost center that a health plan might evaluate as like, oh, this is just another cost for us that we're evaluating and mitigating, to actually having someone and actually having an operating partner. An iSNP is an opportunity to bring care from the health plan and the provider itself to partner with you and your team in the facility and think about how you together can redesign care for your residents in a way that improves census, improves, avoidable transfers and readmissions. It creates more care delivery resources on site for you and your team. And I think when that's done well, like it's a great opportunity, great experience for everyone involved. Like we see that the staff are happier because they have, a nurse practitioner or physician that's actually reachable and on site. They're redesigning how they provide care on site, and it's just like a wonderful opportunity if you can find the right partner that's supporting in an ICE model. And Jill, feel free to add, but those are the few things that come to mind.
Gold star. Great job. I would say I'm going to talk about iSNP from the perspective of like how I first got involved in it and why it had made a difference and what made me so passionate about following this up and spending 20 years on it. Um, as a nursing home administrator, I was not fortunate enough in my buildings to have a Dr. Dan. I had a community doc who had, his own practice in the community and would come in for quarterly reassessments. And then, if something was urgent, there were no nurse practitioners back then. But if something was urgent, I would, we'd call, there's a UTI 5 o'clock on a Friday night, and the response was send him out to the hospital. When, we all knew that that was not the best thing for the patient. It wasn't necessary. It was just an additional expense, additional work. And, the patient would be sitting in the hospital in the emergency room. The family would be unhappy. It just wasn't the way to deliver care. Fast forward, I was working in the corporate offices of nursing home chain and was approached by United Healthcare to evaluate their iSNP for our communities. And I immediately thought, my God, this is exactly what we need to do. Gives us, and this is what I still believe today about all value-based care platforms, but in particular the iSNP, it gives you the most regulatory and financial flexibility to deliver care in a way that makes sense for our population. If you wanted to not have to send somebody to the hospital for a 3-day hospital stay so that they can access their Medicare benefit, you can't do that under fee for service without, an act of Congress to change the Medicare program. When CMS outsources the Medicare program to iSNPs, they give them the flexibility because, as Dan said, the iSNP is taking full financial responsibility for that individual's care. So they get flexibility. They get flexibility around the 3-day hospital stay, around telehealth, around a variety of additional benefits. So it really is a way to deliver care in a way that makes sense for your population, that gives you a lot of more flexibility, provides additional clinical supports, and helps you to deliver the kind of care you want to deliver to your residents. I will also say that it is really important, and sure we'll talk about this. Not all iSNPs are the same. As Dan mentioned, is a model of care, and each one fundamentally at its core has a nurse practitioner and enhanced primary care model, but they all do things differently. And so it's really important to evaluate your options and find out which one is the best fit for you.
Thank you so much for sharing that. It sounds like it is, a sort of all-inclusive model that is taking care of some fairly complex patients. So when you look at the complexity of care that's required for the patients who qualify for nursing home care, how do iSNPs really address that complexity and coordinate care in the most efficient way possible? It sounds like they have flexibility to do that. How do they actually do that? Daniel, do you want to comment on how
Yeah,
your
yeah, I can
team
do that. Well,
handles that
I think
coordination?
I think Jill touched on it. So I think, look, in SNFs, our residents there are some of the most complex patients in the country. They've got a lot of multiple, comorbidities. There's polypharmacy. There are often frequent changes of condition, and trying to coordinate care for those individuals in our standard health system, as Jill was describing often just doesn't work. It's pretty broken. You've got this PCP somewhere off-site. You've got specialists in different systems. You've got, ED visits, and no one hears about what happened. And all of a sudden, the resident shows up back at your doorstep sometimes. Um, you know, Nurses on the floor are trying to like communicate with these folks, and they're not just waiting hours, often days, for something that probably needs to be addressed clinically in a few hours in order to ensure that that person gets the care that they need and deserve, and ultimately the care that would allow them to live in that community safely. Um, I think iSNP's intent is to collapse a lot of that. And it does matter who you partner with. But if you can find the right iSNP partner that has one clinical team that's accountable to you and your residents, that is in the building multiple times a week, that is reachable in real time when they're not there, um, then you change the game. Like responsiveness is everything when you're trying to coordinate care for these folks. And that difference between responding, I don't know, in 2 hours versus 2 days is like, whether or not they need to go to the ED or not. And I think an iSNP and the care team is fundamentally aligned to work with you to try to solve those communication challenges. And I'll give a plug here for Hucu. I don't get paid to tell you this, but like this was one of the reasons why we ended up using the Hucu platform in our model, because look, we've tried a lot of different ways to try to improve communication and coordination of services, and we still use a number of different things and have tried, but we've been using Huku now for over 6 months, and it turns out it's a lot better than emails and faxes and text messages, often not HIPAA compliant text messages, and when you can get people on this type of a tool you can make that type of real-time communication, close the loop and more effective. And, that results in a lot better care. I'm sure we'll get into that later, but when I think about coordination gaps and responsiveness, like, I think these are the things that come to mind. And it's really what separates kind of this broken system to like a really, I think, great experience for the resident, your staff, and the care team that are all trying ideally to work together towards a common goal.
That's awesome. No, that financial alignment to assure that the best quality outcomes, are driving the best financial returns really does help align the team and, make it important to have that care coordination to receive the benefits, right? So we have a quick poll question. Since we do have a fair number of people who are already experienced with iSNPs, we wanted to get a feel for what the real benefits that you're experiencing are. We heard Daniel and Jill talk a little bit about the improved economics, the reduced hospitalization rate. That's a much more satisfying environment for staff to work in. And so we hear that, working in an iSNP can really improve your staff retention and satisfaction because people are focused on the right things, right? They're focused on quality care outcomes. The residents themselves benefit, right? So if you could complete this little poll, we'd love to hear what people see as the most important benefits of iSNPs that they're aware of. And Jill, for your clients, what do they generally see of these benefits?
Um, I would say they definitely experience reduced hospitalization rates because one of the key factors is being able to respond timely. And having that response from a clinician who knows the patient, who understands their history, and also has created a relationship with the family as well. They help facilitate that communication loop, and so that results in reduced hospitalizations, whether it's because they're catching something early or because the family is comfortable knowing that this advanced clinician is contacting them and saying, no, it's okay. Mom doesn't need to go to the hospital. Resident satisfaction and family satisfaction is through the roof. I mean, it's over 90% when you have an iSNP in the building. It really is amazing. And then, of course, other things like other clinical outcomes, and there is an improved bottom line. I mean, one thing that you mentioned, Laura, with aligned incentives, and that's one of those financial flexibilities that I mentioned in the beginning is that the physician's activities, the nurse's activities, the facilities activities are all aligned around the same goals. There are quality goals, and then there are payments that are made that are not just for whatever service it is, but are focused on prevention and getting the right care at the right time. So that's part of the beauty of the model is that you have that financial flexibility as well.
Absolutely. And what we're seeing in the poll is that people really are seeing the
Yeah.
benefits of improved outcomes for
Yeah.
residents, which is, the goal that we all have in mind. And again, why value-based care is so powerful is it aligns the financial incentives with those outcomes. So let's dive into a few more topics. Um, in terms of the benefits that you've seen, how do you achieve those benefits? Where do you need to address what people sometimes call a communication black hole to assure that that care coordination is occurring?
I can jump in. Communication black hole. Let's see. What that means is, as we experience this, is you send that text message out into the ether and nothing comes back, or you send out a fax and there's nothing comes back. I think fundamentally, and this is like going to be the common theme here, is that the iSNP model is much more likely to create a partnership between the SNF operator and staff, the health plan, which is bearing the financial risk, and the care provider that is in your building in a way that completely eliminates this idea of the communication black hole. We have seen that in many different areas, from having to wait for any type of prior auth to having to wait for a decision around, like, I think there might be a UTI here, doc. Like, do you recommend antibiotics? Like, the timing goes from, again, days to like minutes, and it's just because you become part of the same team. And because you're not always in the building, you are more likely to have that clinician in the building much more frequently than any other model. But still, you need a communication channel that serves you. Sometimes it's even like, look, you're in a room down the hall and this person's in that way. Like, how do you communicate efficiently without yelling down the hall to each other? And that's where you're much more likely to identify this need and then choose a solution. Um, whatever that might be. And then it becomes just the standard of how you talk about the care needs of the residents that you're serving. And so, uh, that comes to mind when you bring up the kind of black hole concept. Like it just goes away. And look, like when it's still, if it's there and it's an issue, like you actually feel like you have a partner where you can sit around the table and be like, hey, let's address this. Like, let's figure because this is hard work, and like there is turnover of staff, and so you need to have a partner that's going to be willing to come to the table when things are working and when they're not, and then be committed to solving and addressing when things are not working. And I think in an iSNP model, you're much more likely by far than anything else to get that. And so when we see that happening, you just get a lot of the things that we've been talking about. Like you get the better experience, you get the reduction in unnecessary hospitalization, you get the reduction in wait times for care services that your staff is trying to coordinate. And yeah, I mean, what else is there to say? It's like it
No,
when it
those
works,
sound
it
like some really outstanding, metrics that you're tracking that are improving. Jill, for your SNF customers who are considering iSNPs or implementing iSNPs, what do you think the most underappreciated benefits are of partnering with a high-performing iSNP?
Underappreciated. I think conceptually, one of the things that's frustrated me for years is this bifurcation between who is the primary care team. We see that somewhat now in ACOs where CMS recognizes a physician as the primary care lead. And yes, they are definitely the lead. But when you're talking about people who live long term in a nursing facility, it's the staff who have eyes on them 24/7. And so it really is the PCP, the primary care team is not just the doc, it's not just the facility, is the combination of both. When I go into a new nursing home, it used to take me at least, 6 months and, sleeping in my office or in being there in a snowstorm or, a hurricane before you actually became part of the team. And, so it takes a long time to build trust in a nursing facility. And so you need those clinicians to be engaged. You need them to see themselves as part of the team. And that's what good iSNPs do. They make sure that they are, embedded, that everybody's rowing in the right direction. And that communication is one of the things that builds trust, right? If a nurse knows that they have somebody on the other end who's going to support them in keeping their resident out of the emergency department unnecessarily, then they're going to make that call. But if they just see someone once every couple weeks, that's not going to happen. It's not going to become that first top of mind thing. And the other thing I would say that is noteworthy is, all of the documentation and the interventions that are happening at the iSNP level as well as the communication that you're capturing is gold. It's gold when it comes to survey. You once had just your own documentation to rely on, just your own staff to rely on. And, whether a physician was documenting effectively or not really wasn't something you could be consistent about. And, now when you have an iSNP, you have other people who are also looking and focused at those quality metrics that are going to be important for you to do well in a survey as well.
Yeah, that level of communication automatically leads to a level of documentation and continuous learning. And both of those things are foundational for successful teamwork, right? Like we like to say at Hucu, almost any problem can either be caused by poor communication or solved by better communication. And that communication is just a fundamental component of building trust and building teamwork. Really, really helpful comments. Thank you. So let's keep the conversation going. Let's say you've heard enough about the key benefits of working with an iSNP. How would you get started building your first iSNP partnership? How should you go about thinking about how to identify a partner? What does that look like? If you're a SNF operator sitting in the audience today who are interested, what should their first step be, Jill?
I would say, don't just automatically default to the people who show up at your conferences or the people who reach out to you by phone. There are folks, that can give a great presentation, but there's variation in, as we said, some of the subtleties of the model of care, the way that model of care is delivered, and how each organization philosophically is aligned. And just as much as the benefits that we've talked about are important, the cultural fit between you and whoever that iSNP partner is going to be is equally as important. I have seen really good companies just not work out well when there's a partnership where two people are misaligned. So it's important to talk to as many of the organizations out there as possible. I'm happy to list them out at some point if y'all want them. But get that information and make sure you're having those conversations and that you have an idea about what is it that's really important to you. What is it that you feel are the key elements that you need in your building in order to move forward and in order to evaluate which partner is good for you. And you don't have to be perfect to start. I hear a lot of times from my clients, well, we just need to get this process in better shape before we can implement something like an iSNP because we're just not ready. You don't need to get anything else in shape. This is part of the process. They're going to help you to get ready. They're going to help you build the capacity that you need. So just look for information. Hucu has information. Dan has great information. I have information. But just, expand your scope of knowledge. Don't just, marry the first person you date.
That is great advice. When you talk about the model of care and exploring how it fits with your organization, what are some of the questions, that the two of you have seen be important to make sure that you avoid challenges? How do you really get underneath that fit question when you think about the model of care?
I'd say, fundamentally, the model of care, like we said, is it's nurse practitioner based or physician extender based. But there is a fundamental difference for some organizations. Some have their own physicians and their own nurse practitioners and will bring them into your building. And some will just contract with whoever you've already got in your building. And then some are kind of a combination. But you know that if you have buildings that are spread all over in rural areas, you might need a physician who is helpful with the relationship with the hospital, with getting referrals. Can you afford to just upend that relationship? So that's probably like one of the most fundamental things I've seen in terms of different offerings around that model of care is just the orientation of the organization and what they're bringing to the table, what kind of flexibility. Or on the other hand, it may be great. I would have loved it if somebody could come in and replace that community doc for me. So it's about what you need and then how well they match up.
That sounds like a really critical decision to make for your organization. Daniel, what are some of the common challenges you've seen with facilities when you're partnering with a new skilled nursing partner?
Yeah, great question. First, I'll say, Jill, I really like where you landed on that last question. I think that the people that are involved in the care delivery that are going to be in your building the most are going to be in assessing that is foundational to the success at an individual community level. Stepping back and thinking like, what are the kind of broader mishaps or mistakes and trying to find the right partner? I think I have to say, first is actually not even like coming to the table. Like there are a lot of operators out there that aren't even thinking about asking questions around, is there a different way of doing things than what they're doing today? And if so, what role does iSNP or other value-based partnerships play in how they think about doing things differently moving forward? And I think that's like the fundamental, like biggest mistake. Like I think I'm in my own little bubble here around iSNP, but like when I step back and I look at the broader population of individuals that call a skilled nursing facility their home, um, there are still it's a much small minority that are served by an iSNP. And so I think the first is just as an operator, having a willingness to ask questions about these different value-based programs and which one is the right fit for you at this time, or which combination maybe might be the right fit for you at this time. I think that's number one above and beyond at this stage still. I think number two, then it actually comes down to the partnership. And what Jill said there is key. It's the cultural fit is so important. And depending on the size of your group. If you're a singular executive director, wellness director, one building, then you think about that at that level. If you're thinking about it for as a regional operator or a national operator, you want to think about cultural fit across that spectrum. Ultimately, though, making sure that there is still that alignment within the communities that are going live with an iSNP partnership. Um, when you think about partnership, as Jill was alluding to, you also have to ask, okay, you've got an iSNP that's being operated by a health plan, and then there's a provider group. In some instances, like Scan Embrace, they're one and the same. In a lot of instances, they are different, and you really need to make sure you understand that. And it might even be different for each individual building. If you're, say, a regional operator, you have to assess like, what does this look like in this area versus that area? So I would say that's number two. I would say three is I think maybe I'm getting this right in terms of priority, but I think three is like once you've figured out started asking their questions, you feel like you've got a good sense of who you might be working with. Then it comes down to I think the shared savings, the financial opportunity, I think is a real one. If you are showing up as a true partner on the SNF side to the health plan and the provider group, and you're designing what better looks like, you're going to create real value. And you want to make sure that that partner that's coming alongside of you is willing, if there is value, to share that with you. That sharing should be in the form of a shared savings payment or a quality incentive. And I think you want to lean into that and you want to make sure that your partner is willing to have a candid discussion with you about what is on the table and how that might evolve over time. In the beginning, there's a lot of uncertainty around what will be on the table for shared savings, but if you're doing the right things together, you will generate real value. That real value is going to come in multiple forms, one of which is actually reduction in unnecessary healthcare expenses, which then should flow to you as the operator as additional revenue. I think four, I had five here that came to mind. Four is enrollment. Um, I think once you've made that commitment, maybe four and five are committed. I think it's the enrollment. Like to make this work, you have to be. This can't be a side project, which is kind of what I was thinking about was number five. But like they're tied because it is not a side project. You have to be willing to say there is a substantial portion of my long-term care residents that would benefit from this partnership. And therefore, as a partner, I am willing to come to the table and figure out ultimately how I can create, or share that opportunity to the residents in a way that a substantial portion of your residents should want to come on to this partnership. They should want to sign up with the iSNP and the care team. And so if you're not at a place where you think that you can get to, a reasonable percentage of your long-term care residents being on this partnership, if you're like, yeah, I can give one or two of my residents, it's never going to work. You're never going to get the care team in the building enough. Your staff is never going to get on board because they're not really engaged. If this individual, nurse practitioner or physician is really only serving one of your 50 long-term care residents, so you have to be willing to make a commitment in which you believe you're creating such a great opportunity and experience for your residents that it's going to be obvious most of them are going to want to sign up. And I would say if that's not the case, like it's not going to work out. You're going to go 12 months, you're going to go by. You may only had 3 of your 50 residents that are on it, and no one's really going to be happy. Yeah, I
That
think
sounds
there's
like one of the pitfalls, right? Not thinking about it strategically as you're going to undertake a fair amount of change to increase the level of communication and coordination and focus on quality of care. And in order for that, to make sense, you kind of have to have an economy of scale, right? Where your residents are making the choice and you're educating them about what the best quality choices are so that they can choose something that really works in the long term, for your whole team as well as for each individual resident. So that education on enrollment sounds like a really fundamental component, which I would assume the best iSNP partners are helpful in identifying and helpful in communicating, since you are basically recruiting residents all year long, and every month you can be adding residents. What are the other things that you look for in the right iSNP partner? We already talked a little bit about shared values. What are some of the other criteria, the flexibility around your care model and who you want to either retain or add to your team? What are some of the other characteristics of the right iSNP partner for your community? Oh, Jill, you're muted.
I thought I had gotten myself off mute. I said I agree with all of the things that Daniel mentioned, especially being an active participant both on the front end and the back end. Um, with my clients, we usually take the approach of determining upfront what are the things that are really important to them. Is it that they're looking for improved clinical outcomes? Is it that they're looking for, better financial opportunities? Do they need additional staff? What are the key drivers of why they want to undertake this program? And we look at all things. We look not just at iSNP, but we look at ACO as well, because if you're not willing to do the work that an iSNP takes, maybe sometimes an ACO, a little bit lighter lift is a good way to start. Um, so engagement on the front end and understanding what you want, and then actively seeking out responses from folks as to how they would approach a partnership. Um, and then on the back end, understanding that no one company is going to come in and just do it all for you. They are your partner, but there are internal changes that you have to be ready to take on in order to make this successful. Part of it is the enthusiasm about the partnership and how well you communicate that to your frontline staff, how they understand what the benefits are to them, to their jobs, as well as to the residents. Some of the other areas that we evaluate when I work with clients is just the organization itself. So, who is the organization? Are they an insurance based? Do they have a provider arm? How long have they been around? Are they for profit, not for profit? Where is their funding coming from? And what is their goal? I mean, some of them are out there to just grow really fast and then sell. And if you are a company that is just looking to grow really fast and make money and then sell, then they might be a great partner for you. But if that's not your intention, if your organization is, been around for a long time and you're looking for avenues for sustainability, you want to know that your partner is going to be there for the long haul and that there's not going to be some acquisition that happens, 2 years after you're involved with them. So looking at what the organization, who they really are, understanding what is being proposed. Is it soup to nuts? They're going to come in and do the administrative piece of it. Are they offering you equity? Do you need equity? Do you want equity? It used to be when equity was really important in the beginning, back in 2015. If you wanted to not be working with just an insurer, if you wanted to be with a smaller group of other providers, equity was really important. Now there are so many options, and depending on what size of that equity, it's not necessarily the most important thing anymore. So there are great options that don't involve that. So what would they be proposing as a solution to you? What are they bringing to the table? The care model, how does that care model fit with what you have today or what you need in the future? The financials, what are they offering you, and what is the timing of that? So, what are you getting upfront? Typically, reimbursement, it can go from just a fee for service, and that's how originally it all started out, was like fee for service. Then it was fee for service with some additional value-based components. Capitation is more prevalent now, and then some value-based components added onto that. But what is your experience? How well are they willing to work with you to understand and bring you along? And how attainable are the metrics, the quality metrics that you're going to be held accountable to? Um, and then benefits. I also would look at the benefits that they offer in their plan today and how relevant are they for the residents that you have in your building.
That's great. That's a really comprehensive list. Really appreciate that. And you already dipped your toe into, the financial impact of participating in SNPs, and the different types of models of how SNFs will get paid for participating in iSNPs. What are the financial risks that, need to be considered if you're considering working with an iSNP?
I'll jump in a little bit here, and then I'm sure Jill will have some things to add. Look, I want to answer this carefully. I don't want to over or undersell the opportunity here. I will say though that how in most instances that I'm aware of, the plan still bears the insurance risk or the downside cost risk. And so that direct risk of, oh, if somebody goes to the hospital and it's a $50,000 hospital bill, I'm not aware of SNFs unless there's a joint venture or something like that in a traditional iSNF contract bearing a lot of that downside risk. So then it becomes kind of, when you look at the contract and the structure, uh, how does this impact your revenue today? And I think you need to have a holistic, and you should find a partner that is willing to go through that model with you in full transparency. Because if they're not and you sign and it's not the right thing for you, like you're just delaying the inevitable. It's not going to work a year from now. No one's going to be happy, and then you're going to part ways. And so you need to find someone that is willing to say, let's think about how the revenue flows differently in this model. You're moving most often from a fee for service model into a capitated and shared savings model with an iSNP. And so it's no longer thinking, what are all the different services that I can bill and then get revenue for? I'm actually getting a cap amount, a larger amount of a monthly payment from the health plan for services like skilled days and Part B therapy. That's bundled in. Now, this individual may or may not need those services this month. And how does my delivery of the services that they truly need, how does that impact my underlying operating costs when I think about staffing and supplies? Um, and then um, when you put all that together, plus the shared savings at the end, how does that change my overall cash flow or revenue in the long term? And I think for those people that have done that and created real partnerships, it turns out actually it's much better. It's a better opportunity, and that comes down to thinking, okay, do you have a partner that's willing to break down the finances with you? That's willing to say, hey, let's get an NDA, let's go through, your P&L, and on a community basis, and let's talk about how this will work. And then they should be able to match the contract in a way that at least like early on feels fair. And then you may not get it, but then you have a partner that you didn't get it right, they're coming back to the table and they're making those contractual adjustments so that the finances are working. And you're building a partnership together that ultimately results in, I think, a better margin opportunity for the operator in the long term than a lot of what they're experiencing today for their long-term care business.
Thank you. That's really helpful. So let's wrap it up. We have one more poll, and it's around barriers to partnering with a SNP. So, what do you see holding people back? Why wouldn't a SNF want to participate in an iSNP? What are the barriers that you hear most often? Let's go ahead and pull the poll up while we talk about this. So these are some of the things that we have heard. We'll invite the audience to select which ones they see as being most prominent. And while people are answering the poll from their own perspective, um, Jill, what do you see most often as the biggest barriers to participating in an ISNP?
Thinking you're not ready, thinking don't have enough together or your buildings have too many problems, just assuming that you're not ready and it's not going to work for you or you can't handle it. I mean, you have the conversation and determine that after, but not even exploring it. We started out this presentation with, you noting that in that CMS and two very different administrations have said that there will be 100% of Medicare beneficiaries in some type of value-based care program by 2030. And we are barreling towards that. And the only way I see SNFs being able to manage that is to be proactive and to choose partners because you probably have value-based care contracts happening in your building that you don't even know. You either have docs who have signed up with an ACO and are getting shared savings off of your residents, and you may or may not be getting any of that. So that's one thing. You may have value-based care contracts that give you some type of incentive for meeting quality metrics. And are you actually taking advantage of those? Are you monitoring those quality metrics? Are you making sure that you're going back and checking to make sure that the numbers they're giving you are right? It's some work on the back end to be able to make sure and validate that you're maximizing the outcomes that you could be achieving. So yeah, I mean, I think that those are some of the things that stop people from wanting to engage is just that fear of the unknown. And we can't possibly handle one more thing, but it's here, it's coming. And so it's better to be prepared and risk manage this than just let it happen to you.
That's a great point. If you're not at the table, you're on the menu, right? And so this is happening around you. If you're not being proactive and selecting the best path for your organization and your team, you're going to miss out on the opportunities. So it looks like most people are responding to the poll that it's lack of awareness, for one thing, lack of willingness to really reach out and learn about it, and then misalignment on care coordination expectations. So, we are dealing with the payers, we're dealing with providers. How do we align them all and assure that, we're working together to get the best care outcomes as well as financial outcomes? Really appreciate all of the information that the two of you have shared. Any last thoughts? Hucu is very excited about the opportunity to support organizations who are working in the iSNP environment. Because of the reasons that we said before. Truly value-based care is focused on residents and providing them the best quality outcomes. And as a result of that, they get the best financial outcomes. And leaders like Scan Embrace and the organizations that you're consulting with, Jill, are people who really get it and are focused on the future and looking to gain the benefits of these new care models through teamwork. And communication is fundamental to that. And that's really Huku's contribution to this effort is making it super easy to be responsive and to provide the level of care that every resident deserves and that everyone wants for their own family. Any last thoughts?
Agreed. Agreed. Let's go do the work.